This video will demonstrate a proper nasogastric tube or PEG tube um, assessment. So anytime you have a patient that has an NG tube in place or has a PEG tube, whether it's for feeding or to suction gastric content, whatever the case may be, we want to make sure we're doing a proper assessment to promote positive patient outcomes and to prevent any potential complications that can arise. So anytime you have a patient that has a nasogastric tube in place, we generally want to do an assessment about every 4 hours. If the patient's going to be getting continuous tube feeding, we want to make sure that they are tolerating the tube feed appropriately. If they're getting intermittent tube feeding, often they are going to be scheduled tube feeding every 4 to 6 hours. So we would want to assess before that feeding. We would also want to do a routine assessment every 4 hours. These tubes can become dislodged pretty easily. Patients can cough and it can become dislodged. They can accidentally pull on it when they're turning in bed. It may become dislodged. So our primary concern with nasogastric tubes is to make sure that it is in the stomach and it is not pulled back with the potential for aspiration of content into the lungs. Another important piece of the assessment is to assess the gastrointestinal system, make sure that they are tolerating whether it be suction or tube feeding appropriately, and that they're not having any nausea, abdominal distension, any bloating, constipation, diarrhea, things like that. So all important pieces that will be a part of your routine assessment when a patient has an NG tube. So when I enter the room with a patient with an NG tube, you want to keep in mind patients with these types of equipment, well, again, whether it's a PEG tube or an NG tube, there are going to be times where they're not able to respond to you. So they may not be able to tell you that they're not feeling well, that they're nauseous, or that they're feeling bloated or distended. So your eyes and ears are going to be very important assessment tools on these patients. So when I enter the room, I want to make sure my bed is in a comfortable working position, good body mechanics. So we're going to raise the bed and make sure our side rail is down. We want to check our physician orders. If we're coming on a new shift or we are taking over a patient for somebody, we want to make sure that our orders are in place. So does the physician have the NG tube hooked up to suction? Is that suction continuous or intermittent? Or does the doctor want tube feed going? So when we enter the room, we want to make sure that our connections match up with our physician's orders. So I'm going to look here and say, this patient has his NG tube hooked up to suction. So I want to make sure that my connections are in place, that in fact it is suctioning gastric content. I want to check my regulator to make sure it is at the appropriate setting. And I want to check my suction canister to visualize the gastric contents that are coming out in a patient that has their NG tube hooked up to suction. So good to look at all your connections, make sure we're going to the right place, that we are connected, and that the settings are appropriate. Now, if a patient had tube feeding going through his NG tube, I would check the tube feed pump, make sure we're going at the appropriate rate. I would check the tube feed bag, that we'll talk about in another video, to make sure it is being used within the 24-hour period. And I will check the total intake, again, making sure that we are following physician orders appropriately. Then I'm going to come to my patient. I'm going to do a focused assessment on the NG tube itself and the GI system. And the first and the most important thing that we want to see is the exit site at the nair. Is this number the same that it was reported from the nurse that either placed the NG tube, or is it the same from your previous assessment? So here, my exit site is at 55. Now, if I assessed it at, let's say, 65, my previous assessment, and I come in and now it's at 55, it has become dislodged and we've lost 10 centimeters. So that's an important assessment piece, making sure that this exit site matches the previous assessment. While I'm doing that, I'm also going to take a look inside the nairs. You got to remember, anytime you have a tube pressing on tissue, you have that potential for skin breakdown. So I want to look in the nairs and make sure there's not any redness, any skin breakdown at all. We'll take a look at the oral cavity, make sure we're doing proper oral care, preventing any skin breakdown in the mouth. Again, when patients have NG tubes, they're going to be NPO, so they have a very high chance of having very dry mouth dry, cracked skin. So we want to make sure we're doing that frequent oral care, and we're assessing the patient as we're assessing the NG tube. So I feel comfortable. My NG tube is at its exit site that I had previously documented. We are connected to the appropriate connective pieces based on the physician's orders, and we do not have any skin breakdown in the nares or the oral cavity. So I've done my good, quick, focused assessment up there. Next, what we're going to want to do is obviously you want to keep the patient protected. Don't let them be too exposed here. But we want to do that focused GI assessment. So if the patient's able to respond, we're asking them, are you feeling nauseous at all? Do you feel any abdominal distension? Any discomfort in your abdominal area? Other things we can ask is if they're passing gas. That means we have good gastric motility. And then we're going to listen to bowel sounds and doing some palpation. So we're inspecting first. I'm looking for any increased distension in the abdomen. That means either gastric contents building up or they're not tolerating the tube feed appropriately. So as I'm looking at my patient here, abdomen looks good, non-distended, and equal to my previous assessment. Next, I want to auscultate bowel sounds. Now, this is a very important piece, whether the patient has suction or tube feeding, because we want to make sure that they have good peristalsis, good gastric emptying, good motility, making sure everything's moving forward. So we're looking for good bowel sounds and nothing hypoactive or absent. So I'm going to check my 4 places. If I notice absent bowel sounds, I am checking for a full 5 minutes. Good. So I have normal bowel sounds, meaning that the patient is tolerating these orders okay. Now I'm going to do a little bit of palpation, asking the patient to let me know if they feel any discomfort at all. If the patient's unable to respond, we're looking for any facial grimacing, any discomfort from the patient. So good focused gastrointestinal assessment to make sure that the patient's doing okay. We also want to check for any loose stools. If the patient is receiving tube feeding and has numerous loose stools, it could be an indication that they are not tolerating the tube feed at that specific rate. If the patient has not had any bowel movement, if they're constipated, we may need to get a laxative or some kind of bowel elimination method on board. So a good GI assessment to make sure that they are tolerating everything okay. Another thing to point out, if the patient is connected to suction, when you go to auscultate for bowel sounds, we want to make sure we turn the suction off so we can make sure that we are hearing everything okay without any background noise that the suction can cause. So we've done a good focused assessment of the NG tube itself. We've done a good focused GI assessment, make sure the patient is tolerating everything okay. And again, our biggest complication that can arise from an NG tube in place is the potential for aspiration. So some other things you want to check are the patient's respiratory rate. If their respirations start to increase and we're starting to get tachypnic, there is a potential that the patient aspirated some of either the gastric content or the tube feed. Another thing I want to check is the pulse ox. Check their SpO2 levels. If their oxygen saturations are starting to decrease, there is that potential again that they have aspirated contents and may be developing an aspiration pneumonia and some respiratory complications. So focused assessment of the NG tube, focused GI assessment, and then taking a look at that respiratory assessment. As we're looking at respirations and SpO2, we also want to take a listen to the patient's lung sounds. And we're listening for any crackles, any adventitious lung sounds that are indicating that the patient may have aspirated. So in my assessment here, everything looks good, everything sounds good, patient seems to be tolerating everything okay, and I'm feeling pretty comfortable with how everything is set up here with my patient. One other thing to point out, so we talked about NG tubes there. There are going to be the times where your patient has what's called a PEG tube or a G tube, which is a gastrostomy tube, and that is a tube just inserted surgically directly into the stomach. And this is kind of what you'll see here on your patients. It is inserted, you have a stopper on the inside preventing it from coming out, and then you have a little kind of bumper here protecting the patient's stomach. So what you should always see if a patient has a PEG tube is some kind of fenestrated kind of 2x2 or 4x4 here. And this is to protect from any potential drainage that the patient may have, and really to prevent any type of infection. Because remember, you have a surgical opening at the entrance of your PEG tube here. So my assessment for a patient with a PEG tube is going to be very similar to an NG tube. Again, remembering anytime you have a tube coming into contact with tissues of the body, you have that potential for skin breakdown. So I'm going to look and potentially remove this fenestrated 2x2 or 4x4, but what I'm really looking for is the skin underneath where this bumper is, making sure we do not have any redness, any irritation, any raised skin, any kind of skin issues due to the tube being in place. So I want to check that. Everything looks good. And then I would do the same thing with my GI system. I would listen to bowel sounds, I would inspect for any distension, I would auscultate, and then I would do palpation just to make sure our patient is tolerating everything okay. Again, we have the towel here just to make sure we are protecting the patient, making sure we're not causing any unneeded mess, making sure they're in a comfortable position. Another very important thing to assess when you're in the room is the head of the bed level. Anytime a patient has an NG tube in place, we do not want them lying completely supine. We want the head of the bed at least 30 degrees. Another thing we can do to help communicate with everybody else on the healthcare team is to place a sign above the bed, and that sign will say something along the lines of, keep head of bed elevated at least 30 degrees at all times. So that's a good just communication method to make sure whether the nursing assistant personnel, the physicians, dietary, speech therapy, respiratory therapy, whoever's helping care for this patient understands that when they leave the room, we need to make sure we keep this head of bed at least 30 degrees to prevent aspiration. So that's another important thing when you enter the room to make sure it is in the proper position. That pretty much sums up a very thorough nasogastric tube or PEG tube assessment. Again, we want to prevent complications, promote positive outcomes for our patient, and by doing a good thorough assessment, we can ensure that those things happen. In the coming videos, we will talk about doing intermittent tube feeding and continuous tube feeding, and you always want to perform a focused assessment prior to initiating those as well.